Okay, welcome to the last panel of the Health and Adult Social Care Scrutiny panel of this municipal year. Just before we start, can we introduce the panel members to people? So I'm Jackie Ramsey, I'm chair of this panel.
Yeah, I'm Councillor Bill Armour, member.
Helen Clay, voluntary co-optee. Kim Taylor, voluntary co-optee.
Councillor Joe Lawson.
Leslie Warner, councillor for Combe Valley.
Alison Munro, councillor for Almonbury Ward. Thank you.
Lovely. And do you want to introduce yourself, Richard?
Yes, it's Richard Dunn. I'm the supporting officer for the panel.
We'll just go through the basic things first and then welcome our guests, if that's okay. So, do we have anybody who wants to declare interest today?
Just Governor for the Trust. Whoops.
We'll try and sort that out for you, Leslie. Thank you very much. Okay. It is a public meeting, so if anybody from the public's here, then that's brilliant. Do we have any deputations or petitions?
None received, Chair.
Any questions?
No.
Okay. That brings us very neatly to our first item, and I think Rob and Jackie are both available online, and we've got Richard Parry in the room. Rob, are you going to present? Is it you that's presenting, or is it?
Yes, I'll present if that's okay, and then we can open for questions if that's all right. Richard, I'm not sure if you wanted to do any introductions or anything. Sorry, can you hear me okay?
Yes, we can hear you okay.
I think, Rob, do you want to just start?
Okay, I will do. Right, firstly, apologies for the mix-up. I've tested positive for COVID. Felt dreadful this morning, but the paracetamol's kicked in, so I am here. So apologies for the mix-up earlier. Right, so the paper today is here for information for the scrutiny panel. There are 3 statutory duties that the Safeguarding Adults Board has to undertake. One is to produce a strategic plan. The second is to do an annual report on the progress on that strategic plan. And the third one is to undertake any safeguarding adult reviews on any cases which occur during the year, which we feel there would be some lessons learned for any of the agencies involved in that. And you'll see within the report there are 2 such cases that we report on. But I'll give you some general background first on the report and the background to the Safeguarding Adults Board is enshrined in the 2014 Adult Care Act, and it's that forms the body of the board. Now, page 10 of the actual report, which was circulated, is probably the best outline for how we actually operate. And our vision as a board, as quite a large partnership in Kirklees, is to work together to take action to keep the people of Kirklees safe from abuse and neglect, and putting people at the heart of everything that we do. So that's the vision for the board, and underneath that we've outlined how we actually undertake to work towards that vision. As I said, we're very fortunate in Kirklees to have a very strong partnership and a very committed partnership. And you'll see from the attendance within the report here, people are very active and the agencies are very active in Kirklees as to how they actually work together as a partnership to reach that vision or to attain that vision. So the priorities that we focus on are leadership, protection, prevention, learning and assurance. And that is at the heart of this report and of our strategic plan. We undertook a development session earlier last year, and to really try and focus our work of all of the different partners. And we came to a conclusion that we decided we wanted to focus on last year, that we're reporting on building a confident workforce, learning from the experience of COVID, and to improve the communication across the partnership. And in doing that is to do it through some more active listening. So really being using our partnerships and our contact with the community to actually go out and see what the lived experience of individuals are and how that impacts on our own work. Now, the rest of the report really outlines how we actually undertook that in the previous year. And the subgroups, again on page 10, are outlined there, that we have a quality and performance subgroup, the safeguarding adult review subgroup, and a learning development subgroup. And we also have the strategic group, which stands over all of those. I'm pleased to say that all of the partners each chair those groups, which is a strength in Kirklees. So we have partners from the police and from our health colleagues who actually chair each of those subgroups there and oversee the work of that, reporting into the overall board there. And the report itself outlines the work of each of those subgroups. And if I go to the first one, which was the SAR subgroup, you'll see that we've reported on 2 safeguarding adult reviews. That's one for adult N and one for adult O. As in all cases, these are always tragic and very sad cases. And we undertake these reviews so that we can gain some learning to try and minimise the level of risk so that these events don't happen again in the future. Adult N was a very sad case of an individual who suffered from alcohol abuse and self-neglect. And the undertaking of that review really focused on any gaps between the services and how services helped with the transition and the difficulties they faced within that. Within this, an action plan's been put into place, and each of those lessons learned are included within that action plan. So we're trying to minimise the chances that this type of occurrence can happen again. Adult O, again in the same year, was a younger girl, individual, an adult, who suffered from severe special needs. And here again, it was within the transition into adulthood where we felt there was more that could have been done in this particular case. And again, there's groups being set up, task and finish groups, to see what lessons were involved in that and how they can be put into practice. And again, the report outlines some of those. Our quality and performance subgroup has been working to try and develop a new dashboard for the board so that we've got a better feel and vision and sight on how we're progressing with safeguarding adults across Kirklees. That work is still undergoing, but we've taken some lessons already within that, and we've had a shift in focus more onto our multi-agency data that we collect and our KPIs that we utilise within that, but also within audits that each of the agencies provide within there. And that's a shift because in the past it's tended to be more dominated with statistics from our adult social care colleagues, and it seems to have been unbalanced in the past. So we're having a more holistic approach to that particular subgroup and around providing us with some more assurity that we're actually working in the right direction across the whole of the partnership. And the third group, the learning and development subgroup, has continued to work right throughout the pandemic. And they've undertaken, I think it's 28 sessions in total were delivered, plus 3 major events in dignity and care, the outcome from our safeguarding adult reviews, and also an event on trauma-informed practice. That's in addition to our Safeguarding Week, which we undertook in November to try and raise the profile of the work of all of the services within there. And on top of all of that, we've been undertaking some lunchtime bites, which is a session where individuals from any of the agencies can actually attend during their lunch break to gain some insight into whichever subject is there. So it's been a very busy year, even in spite of the COVID and the distractions that we had within there. Now, all of our work and our development of our strategic plan and our action plans which follow are informed by an event that we run annually, and that's the challenge event. So there's a group of us who actually meet with each agency individually, and we go through and we challenge each other on our progress around the intentions of each of those agencies during the year with safeguarding adults. And we use the information that's gleaned from that to go to a development session from which we actually create our new strategic plan, and hence the cycle is completed with the annual review. In that previous year, the challenge event really was looking at transitions and partnership working was the main two issues that actually came out from those challenge events. I'd just like to report, because this report is coming to you a little bit later than we'd normally intend. It's usually here around January time, so we are a bit behind with this. So I thought it might be worthwhile just ending on the fact that we've completed this year's challenge event, and the outcomes from that, just to bring you right up to date, we've found from each of our agencies that COVID's not gone away. I've just tested positive myself. COVID's not gone away. All of our agencies are still struggling with it. Now, the opinion in the general public may be that it's disappeared or it's waned to a great extent, but that's not the case for our agencies. They're still right in the midst of actually working with with the pandemic and its effects. And we're seeing that is coupled with a greater complexity of cases across the board, both within our council colleagues, our health colleagues, police. All of the agencies are seeing an increased complexity of the cases that they're dealing with, and an increased acuity of health issues that they're having to deal with. Now, we've surmised, and a lot of reasons for that is probably because people have been avoiding attending health agencies whilst in the midst of COVID, and also people's routines have been stopped or eradicated because of the inability to carry on healthy routines within that. Hence, we feel that people are actually having more complex issues which are presenting to our agencies, which is incredibly challenging for our workforce. And this is the second thing that's come out from the challenge sessions. Our workforces are incredibly challenged at present times. We're finding retention and recruitment incredibly difficult across the board, and also those people that are within the services are having to deal with the increased acuity that I've mentioned, the complexity of the cases, which hasn't abated, and there's been no break, there's been no let up since the pandemic. So that's the findings we're feeling right now from the challenge events, which finished 2 weeks ago. So that's the completing of that. That will feed in again to the next strategic plan, and hence the annual report next year. But that kind of concludes the presentation from myself, and we're open to questions from the panel. Thank you.
Thank you very much, Rob, and thank you for that update about the last couple of weeks. I can definitely hear an echo. So anyway, and to be fair, we're coming on to discuss some of the things that we've learnt this year a little bit later, and certainly the complexity, the increased acuity and the workforce issues are very high on our agenda too, so, or at least noted by us very, very much. Shall I just ask before we start questions, Jackie or Richard, do you want to add anything at this stage? You're happy to just go straight into questions?
Happy to take questions.
Jackie, just to note, we can't hear you, but we are going to go straight to questions if that's okay. All right. Bill.
In fact, there's several things I noted as I went through. This whole aim that the Quality and Performance subgroup talks about, aim to be proactive rather than reactive, which we hear quite a lot, and obviously it's a great way forward. But given what we've just heard and what we already know, in reality, have you got the staffing and resources to work in the way that you would ideally work? Because, I mean, it's this word challenges that you're trying to give care as highly personalised care and achieve equality of outcomes and all these wonderful things that we all wish. And you're up against the wall a lot with staffing and money. So I just wondered, if there is a large degree of frustration that you're not able to do the work that you would hope to do to the standard you would like to.
Should I pick that up?
Yeah.
I think the point of all of these, I guess, is to set a level of aspiration in the system. But you're right, many parts of the system feel that they're not able to deliver against that aspiration. So I think everyone working in health and social care would want to deliver a very personalised outcome. But when workforce shortages mean that time is incredibly tight, that means that people don't sometimes have the time that they would want to spend with individuals. And that's not necessarily a universal experience, but it does become a risk that the system is more pressured, and so people aren't able to work in as personalised a way as they would want to, or we don't get the same level of consistency of support because you have staff turnover working with individuals. So, yeah, this is very much setting out a set of aspirations that I think everyone working in the system would want to see delivered, but yes, there are some practical challenges to delivering those at the moment.
I was just struck by one of the examples you gave of the difference that I can't remember which page it was on now, the difference that COVID had made. It was called David's Story on page 25, and how pre-pandemic there was lots of positives. And as you read through it, you felt desperately sad that his world seems, in his eyes at least, to have changed forever, because he is vulnerable and he can't do the things he did, and he's clearly anxious about COVID, whereas many of us have not exactly think it's gone away, but we've just thought we have to learn to live with it. And it just really struck me when he said, this has really scared a lot of people we know. I know we have a vaccine, but there's always a worry to get bad again. So the mental health is clearly on the increase. And it's staffing and resources and how much volunteers can help bridge that gap a bit in the befriending, which I know is really strong.
Rob, do you want to come in at this stage? Do you want to pick up from the previous part as well as the COVID?
Okay. Well, if I pick up first about being proactive, I think the board is there as an overarching multi-agency body, which is to provide assurance to the whole partnership that everybody's working well towards reducing the risk of any abuse. The actual people who carry out the work are the services themselves. It's not the board. And I think there is a general sense of frustration within the agencies. They'll always want to do more, and they'll always aim to do more. I think the proactive work can be seen in each of the agencies through some of the audits that they undertake and their preparation for how they would look forward to solving some of those issues. If I give you an example, I mean, Richard can give you chapter and verse from adult social care, but from our health colleagues, if I can pick up that, they're looking to recruit now from places like Philippines, South Africa, and other areas. In the main, it tends to be those two countries that they're actually going to try and bolster up the workforce. But in addition to that, nationally, they're looking at a campaign for recruitment and training. So that we do have a workforce which is there. The other aspect is looking at retention of staff and making it more appealing for people to come back out of retirement, back into those roles. But the work is challenging. It has to be accepted that the work is more challenging now than it was pre-pandemic, and we've still got to deal with those acuities. So there is a proactive energy within all of the services to try and deal with these issues. That is there, and it's very evident within that. Looking at the legacy that you mentioned with David's story, who presented to one of our sessions within that, I think it is trying to make safeguarding personal. One of the reasons we invited David to actually speak to that, so that people can actually see firsthand what the impact has been on individuals and how we might best position our services to actually support them. And that work is ongoing within there. And I think the risk hasn't gone away. We might have mitigated it to some extent, but we have got to continue the challenge of actually meeting that challenge and trying to see how much we can actually put in place so that David can actually engage with society in the way that he used to. So we do recognise it is more difficult for individuals now than it has been in the past, and that's something that our services are attempting to step up and meet.
Thank you, Rob. Jackie, I noted your hand was up earlier. Do you want to come in?
Yes, I was just going to add to that in relation to the subgroups, the members that attend the safeguarding leads of the organisation, and we're being lucky enough in Kirklees that they've not been pulled, if it's health partners, into clinical tasks. They've been able to maintain their safeguarding role for advice and support, and they're the people that attend the subgroups. So we gain, in the quality and performance subgroup, we gain an agency highlight report, which is what Rob alluded to, in that we gain a good synopsis of what's happening in each agency at the time, and we can change the questions of that because we know, obviously, with safeguarding, it's an ever-changing landscape, to gain that assurance. And then we triangulate that work through the other subgroups, and if there's something that we need to be proactively doing, we would do that immediately, either via escalation with the board members. So I just wanted to add that kind of practical, how it works in practice. Thank you.
Leslie, do you want to pick anything else up on in regards to that?
Not that, but I do have another question, but if you want to go to someone else first. It was just... Take my hearing out. It was just that we had our regular rural update recently about the work of the police, and when I was looking on the page on 29 on the West Yorkshire Police, we are aware that they have to pick up some people who are clearly disturbed in a variety of ways. And they talked about they'd piloted a police sergeant working in the safeguarding team, but funding had been a challenge. And then it talks about processes, and I wondered if that post was still in existence, because I know that training young police recruits to deal sensitively with people with major mental health issues is an enormous issue. And it's very easy to see people out of control and just think they're drunk or they're whatever. So I just wanted to, does that post still exist, was the question, and if so, is training going ahead as successfully as it can do?
Jackie, did you have your hand up for this?
Yep. Yeah, so the police officer still sits within the safeguarding operational team at front door. She's extremely proactive, so anything that's coming in, the police actually spoke about it in the challenge event. She takes back any imminent learning and delivers that to staff immediately. But yeah, she remains working at front door.
Thank you. Alison, shall I move to you?
Thank you. It may have been answered, this question, but my question was, what's the biggest issue that you're facing at the moment? And you may have answered that. The other question I highlighted was, is it okay to mention that? Is location of where risk was identified, which was in care homes. That was the highest risk area. I just wondered if you could explain the reasons behind that, the underlying reasons. And then just one other question was about the you reliant upon resources of the board through financial contribution as well as in kind. So how reliant are you on on donations effectively? And I know that Kirklees are the biggest provider of the funding for you, so I just wondered how sustainable that was as well in such a large amount. Thank you.
I think those are for you, Rob.
Thanks very much. So the areas of biggest risk, I think I kind of touched on really. It has to be the challenge to the workforce and the increased complexity and acuity of the cases. That has to be the biggest challenge that we've currently got. The local authority, Richard's probably better placed to actually talk about the care, but just to give a touch on that, there is oversight of all of the provision of care homes and how they're quality checked by CQC. So we do get reports there, and there is active intervention or oversight from the adult social care and the council, as well as our health colleagues as well within the nursing home aspect of that. So that level of oversight is there, and there is direct intervention when required within that. With regards to the resources, the percentage of a resource coming into the board kind of matches what happens nationally within that. So the statutory partners are our health colleagues, the local authority and the police. So they're the three statutory partners that we have, and those are the three funders. But the actual work of the board is wholly reliant on the commitment and involvement of the vast array of agencies, including those statutory partners, but others as well. And I have to say, I've been here almost 2 years now, and I have experience of other boards elsewhere. And I have to say, in Kirklees, your partnership is incredibly strong, and the level of commitment from the partners is very, very high. All of the events that we mentioned within the report are got really high attendance and real involvement from people, and the learning travels much further in Kirklees than we see in other places, and that's because of the nature of the partnership and the nature of the involvement, and a lot of that is in-kind work, and without that we wouldn't be able to operate at the level that we do. I hope that answers your question.
Oh, sorry, just in relation to the risk in care homes, is that due to the workforce and complexity of cases? Or sorry,
Bob Richards answering, sorry.
So we often have a conversation about what the numbers tell us. So, for instance, if we run an awareness raising campaign and the numbers of safeguarding issues reported goes up, is it because they've actually gone up or that there's more reporting? And so if you look at a care home environment, it's a highly regulated environment in which everything is very visible. And so typically care homes will report almost at a very low threshold for reporting an issue. That's not to say, therefore we're on a bit about, is it actually that more people are actively at risk, or are you in an environment in which everyone's much more aware of safeguarding issues and are reporting things with quite a low threshold, where that same thing were to occur in another setting might not get raised and reported through as a safeguarding issue. We think it is typically about a reporting issue rather than that care homes are themselves a highly risky place for individuals to be. It's much more the nature of the environment in which things are seen 24/7, whereas in your own home things are much less visible, and so it's, I think, much more about the environment and reporting rather than that there's significantly more risk. And there are equally conversations about, I think, from time to time, about if you look at a thing across the system, so medication error, for instance, medication error could happen in a number of settings. It could happen in a hospital setting, it could happen in a care home setting. There could be a moving and handling error, it could happen in a care home setting, it could happen in a hospital setting, and so on. And probably one of the things we probably need to look at is whether there's differential levels of reporting compared to the numbers of people for whom that could possibly occur.
Thank you very much for clarifying that, Richard. Thank you.
Great. Can I come back to you then, Helen, please?
Yeah, actually, my question is very similar to the one that's just been answered, but it was more specifically about deprivation of liberty. There's deprivation of liberty, then there's a section 42, is it? Just that they seem to be increasing year on year. It was really helpful to have that information in there about DOLS applications year on year. That was helpful to me to be able to see the progress or reduction or whatever. And I don't think we've got that for section 42. We do have some of that, actually. Sorry, I apologise. But the fact that that's now growing, I could make some assumptions from that. But I wanted to check and clarify those, and sort of alongside the figures of DOLS applications by disability. We've got people with dementia quite high, mental health, but I think there was sort of people with learning disability. It was just sort of drilling down a little bit into that as to why there's an upward trajectory if it had reduced at some point.
So if we go back far enough in time, there wasn't really a concept of deprivation of liberty safeguards, and then there was the Cheshire West judgments, a case law rather than statute law. And over time, that case law evolves and people's understanding of it becomes clearer, or there's another case law judgment that brings another cohort of people into scope. And so some of that upwards trend is about just people with more complex needs living longer. Some of that has been people reflecting on some of the practice in the pandemic and thinking, well, actually, is this restricting someone's liberty? So if you think about, if we take, there's a time, wasn't there, where if we had COVID, we were self-isolating. Well, you or I might consent to that, but somebody who doesn't have mental capacity and where staff are encouraging them to self-isolate in their room in a care home, well, that was effectively a deprivation of liberty because they weren't free to use the whole care home. So some of this has been about kind of custom and practice changes. Some of this has been about growing awareness. Some of this is about the increased complexity of need that people have, typically associated with not having mental capacity, which draws more people into scope. And we've been waiting for a number of years, or a few years now, for all of these arrangements to be reviewed. There's liberty protection safeguards is what's going to replace the current arrangements, and it's sort of been on the cusp of coming for quite some while. We've got some guidance now, but no implementation date, which will tidy up a lot of arrangements which have, as I say, evolved over time in response to case law. And that's why numbers are going up. I think there'll be a bit of a reset probably when we get into liberty protection safeguards and we're much clearer about what is and isn't in scope.
Thank you. So these figures, are they analysed then to see if they are particularly by a particular area there is a higher proportion of DOLS applications, or by a particular care home, or, is there analysis of that in terms of, because there is still, as I understand it, there's still an element of interpretation, obviously, and quite rightly, to use the skills of the social workers in assessing someone's mental capacity. But just in terms of, because they're quite serious, to deprive somebody of their liberty, and that sort of understanding of the increase in it and also the increase by disability. And similarly with Section 42.
So, one of the challenges about deprivation of liberty safeguards is, you're right, there's a level of interpretation. So somebody living with dementia in a care home where they say they'd like to leave and a staff member intercepts them and suggests, why don't we go and play a game of X? And just skillfully moves them away from trying that door. We're still depriving that individual of their liberty. Even though you might say, well, actually, we'd kind of recognise that if we would say, that's fine, just go out the door and down the road, that would appear a very reckless thing to do. So some of this is in a sense the legal framework associated with things we'd actually recognise as being good care and support for an individual, rather than deprivation of liberty in the way of we're preventing people from doing something because they are being imprisoned in some way. And so different care homes, in a sense, will apply sometimes a different level of judgment about, well, when they intervene with an individual in that way, the extent to which they're depriving them of their liberty, and therefore they should be making an application to regularise all of that. The responsibility sits ultimately with the care home to make some of those judgments, because they are the body that an individual could bring a kind of claim against. So there is some analysis, because there are continuing training programs with kind of care providers to make sure they understand their responsibilities. But it's not the same as perhaps reporting a safeguarding issue which could link back to the quality of care. It's much more, it's hard to describe, but in a sense it's the extent to which people are, it's not the care and that people are providing per se that might tip someone into making a deprivation of liberty request. It's much more someone's individual capacity and their judgments about that. So it's not good or bad that a deprivation of liberty safeguard has been made per se, or request has been made per se, but doing so would demonstrate people are thinking through the issues of the sorts of care they're providing and the legal framework that they're doing that within. But increasingly, the interpretation has got broader and broader. So if someone lives in their own home and support, in their own home, but with quite an intensive care package, and the carers do that distraction, that would count as deprivation of liberty. If someone was out and about, and a number of people with learning disability might have 2 people supporting them in the community, and if they are intervening to kind of guide someone away from a particular situation, that could be interpreted as a deprivation of liberty. So it is quite a complex area, and the numbers don't necessarily mean, high doesn't necessarily mean good or bad.
Jackie, do you want to come in on this bit, please?
Yeah, I was just going to add that there are actually protective measures to make sure that the least restrictive practice is happening. So a good example of that, say someone's on some form of sedative medication because there's a need, that's when that's no longer needed, they no longer take it, and that's the part of the assessment process, so making sure that anything in relation to that person's direct care is the least restrictive practice to support that, and that's the protective measure. So it's a form of protection rather than a negative thing, making sure that everything that they're receiving within that care, whether it's in a hospital, care home, or in the community, is the best to meet their need without being over and above. Does that make sense?
Thank you. I was just, the sort of main body of my question was around how is that information used to improve quality and performance, and the question was, is it used to improve quality and performance in terms of the training that's given and feedback to maybe particular establishments, or I'm not saying that it's a negative thing. It could be seen as a highly positive thing that people are recognising that they're depriving people of their liberty. It was just, is there another sort of string to this bow?
Yes, we'll have an understanding of the profile of activity from different care homes. So if a care home was making no referrals, we'd likely be in a conversation with that care home just to check their understanding, because whilst the decision to refer sits with them, we'd expect to see a level of, there'll be a profile of activity, and for instance, a care home that predominantly specialises in supporting people with dementia, you'd expect to see a somewhat higher profile than perhaps a care home that supports people who aren't living with dementia but have got more physical kind of care needs. But nonetheless, you'd expect to see a level of activity from different care homes. And so yes, there will be a level of understanding of how large is that care home, who is it that they are supporting, what's the activity levels we're seeing. But that sits alongside lots of other soft information we have about particular providers. So we'll have a sense of feedback from care professionals going in, we have a number of staff that support care homes with quality, and they'll have a sense of what's going on in homes. So it's typically not any one thing that we'd kind of say, aha, this care home typically delivers outstanding care except for deprivation liberty issues. It's typically we see a package of things that might lead us to say, are we confident this care home doesn't need any more support around training?
Thank you. Kim, did you want to come in?
Hi, my questions were just based on some of the discussions that have just happened. Location of risk in care homes, 1,019. Again, I know we've had that discussion just, but it feels exceptionally high. And would you say that there's some over-reporting going on? And if there is over-reporting, presumably that involves some work. And is it basically kind of a training need of the staff? Because you mentioned maybe a single medication incident or a moving and handling risk. Would that be considered as a safeguarding risk? And if not, then is there some opportunity for educating about reporting and what does it mean? What is the risk involved in safeguarding? And the other was just an observation really in the types of abuse. I know it's 21, 22, but 51% down to neglect, which is really sad and really concerning. And I wondered whether that was an exceptional trend based on the COVID situation, where there's a lot more social isolation going on. And is there any view of which way that's going now, or was that kind of a kind of standout, or generally what has the trend been out of the COVID years?
So, Jackie, I don't know whether you want to come in a bit more around the data, and it says we welcome people raising concerns, and then we make a decision about, is this something that meets the safeguarding threshold, or is this something about just a more general quality improvement concern? And Jackie can perhaps talk through the work we've been doing over the last few years to welcome reporting, never really see it as over-reporting, but make sure it goes down the right pathway.
Yeah, so neglect and acts of omission is always kind of one of the highest trends, and I think when we look at the care homes and domiciliary care, sometimes it's the unintentional abuse. So it's maybe something wrong with the policy within the care home, for example, that needs tweaking. I know a good few years ago when I was practicing as a social worker, they brought out the red aprons for people who were delivering medication, because if you're the highest senior most member of staff in that, people were interrupting people, and that's when the medication was happening. So that is always a field, but we're highly lucky in Kirklees that we have the care home early intervention and prevention team who do a lot of work. So they look at quality, pre-safeguarding, and even going back to the Declaration of Liberty Safeguard, as a best interest assessor, I was a best interest, it's another level of eyes into that care home. So as Richard alluded to earlier, there are the places where there's a lot more visibility, so that it's going to look at that there's going to be more referrals because more people are seeing things, and it clearly then things can get addressed appropriately. But neglect and act of omission is always one of the highest trends within that.
Thank you.
For those reasons.
Okay. Oh, Leslie, go on, and then it's my turn.
Oh, no, you go.
Well, I was going to sum up.
It's me being a little naughty, but this is my last one, so forgive me. Again, something that I found really depressing when you talk about deprivation of liberty. My mum got Alzheimer's. She was in a care home for the last 6 years. She was lucky. One of my sisters lived nearby. My mum's soul and spirit that passed on to all of us was outdoors and trees. And one of the ironies is that we believe safeguarding for older people with the conditions is locking them up in homes. We know why, in front of a telly and whatever. And I used to say to the social workers, my mum's only problem was she walked like 22 miles at night to where she used to live. I used to say, you tag prisoners, why at some point couldn't we consider those who are marginal and who can cross roads and not? And then someone goes around at the end of the day and picks them up, and they've been free in the day. Wacky off the plot may be, which is what the social workers thought, but I'm always trying to think of how we look after our elderly in a so-called civilised society. I'll leave that with you.
So it's not entirely wild and wacky at all. So in a story I tell because it illustrates things well. In a previous council I worked in, it was a very rural area, and people in the village were concerned about an elderly person who was seen wandering at night. and family were equally kind of concerned to hear this. They didn't live in the same village, not a million miles away. And we initially put in a piece of technology called Just Checking. It's a set of sensors, and what we did was built a pattern which said actually this person was going out of an evening, but they're also coming back again. It was a fairly regular pattern. So we had the conversation about what this with the family, and this person used to have a dog. And so what we recognised was actually they had had a pattern for much of their life of walking a dog of an evening. They didn't have a dog now, but they had reverted to that pattern of activity. So we then talked about, well, we could leave this in place and the family could access it, so they could just get an alert when the door opened, so the person went out, and get an alert when they came back again. We could combine it with some GPS tracking, which was it's called geofence. So actually, if the person remained in the village, they weren't tracked. No one, their family couldn't see. But if they moved beyond a defined barrier, then an alert went to the family. And there were obviously a set of conversations about, kind of human rights and managing risk, because it didn't eliminate risk entirely. That, it could have been really foul weather and they went out inappropriately dressed and they remained within the geofenced area. So people wouldn't have been tracking them, but, there would have nonetheless been a period of time which they were exposed to risk. But nonetheless, there's a discussion with advocates about the best solution. So those things do exist, and we absolutely actively promote different forms of assistive technology for anyone who's got, so I've got 2 children, and Find My iPhone is effectively that, because you know where they are. And, so actually, some of this has moved beyond that specialist technology to recognising that there are lots of things that effectively allow us to get into some of those conversations about how do we use technology to enable people to take a good level of risk. Associated with really good design, because actually a really well-designed care facility will enable people. So come across really good extra care housing schemes that are built around a courtyard, and effectively everyone's flat door opens onto the courtyard, so that people can go out and wander, again associated with that door technology, so that staff know when someone's gone outside, and if it's a lovely summer's evening, the door opens at 2 a.m, they won't be as concerned as if it's in the middle of winter. So there's a whole set of things we can do that will try and balance off, and then I think it's about a conversation about positive risk taking. And back to the deprivation liberties start of the conversation, there was one of the judges considering a piece of case law said, a gilded cage may be gilded, but it is still a cage. And so there's something about in all of this recognising that balance of kind of risk and freedom, and working through, as Jack was talking about, those best interest assessments about what is the best solution for an individual and what's an appropriate level of risk, and involving, the individual families, advocates, and all of that.
Thank you, Richard.
Can I just finish by saying I hope the technology's developed enough so that when it's my turn, I'm free to roam in woods and wild mountains. That's all.
We hope so too, Leslie. Rob, I think you're first, and then Jackie.
Okay, thanks for that. One of the principles that we have around safeguarding adults is around making it personal, and it's important to hear the stories that the councillor just relayed. I think the decision to deprive someone of their liberty is based around safety, and there is the danger of the gilded cage that someone mentioned earlier. There's a real danger of wrapping somebody up in cotton wool so that they can't move. They'll be perfectly safe, but they'll have no life within that. I can reflect on my own mother, who got early onset of Alzheimer's in her late 60s, or early 60s, about 65. And she ended up in a care home for over 10 years. She was the longest resident in the care home at the end of that. But the dilemma to actually move her into a care home was that discussion that professionals have all the time and family members that have all the time. My mum wanted to stay in her own home, which she loved and adored, and she had her friends and everybody, and we had to assess the level of risk or protection that which she had around her with her friends and her family who could look out for her. But it got to such a stage where it became too risky. And it was that very difficult stage where we had to then put her into a residential care facility within there. And that's the dilemma that family members have, but professionals have as well. And at the heart of all of this is the legislation around dolls. It's why it's there, is to make sure that we are cognizant of the decisions that we have to make and are very clear about the decision-making process in each of these, because it's such a serious thing to deprive somebody of their liberty for their own safety. And it's a real balance and dilemma that we face in all of the deliberations that a social worker has to do. Is focused around that, and that family members have to do. And it is very difficult. And there are ways of actually easing it as much as we possibly can. And I think the design of our care facilities and the design of our home care now is such that we are in a much better place than we were, say, 10 years ago. My mum used to wander a lot, and that's what I don't know how many miles a day that she would have walked. But the design of the facility she was in was there were no dead ends, that you could walk in a circle. That doesn't sound very technical to people, but the change that made for my mum, that she would get distressed when she came to a dead end, and there was no dead ends in this new facility, so she could wander freely, and that eased her distress greatly within that. So all these factors are now considered, and there's more improvements we can do, but it is much better now than it was 10 years ago, for sure.
Do you want to go ahead, Jackie? Thank you, Rob.
Thank you. So just building on that, I was a best interest assessor, and I think, we look at making safeguarding personal. That should be embedded in through everything that we do, not just safeguarding. It's about that personalised care. So as you alluded to, some people are very much outdoorsy. I've been involved in things where we've built into the care plan someone going out with the gardener. And, there was a very key gardener, so building that in so that, it's not the least restrictive option. They can get out. In addition, working with the sector, is there any walking groups? Obviously being safe, is that it would have to be risk assessed, but can they get out? And that be built into the care plan. It's about speaking to those who know them the best and what their past experience and wishes would be to try and build it in the safest, most least restrictive option. That's what the DOLS assessment's there to do. Thank you.
Thank you. I've just got one question actually, which is really around our front doors to services, because what we've discussed a lot is around how safeguarding works to those people that we know. But you did talk a little bit earlier, Rob, about being proactive. And I do think that we've got a lot of risk out in the community, certainly following on from COVID. I know we're a good year after the lockdowns and such, but it was building in the community was that risk. And we acknowledge that services have only got a degree of capacity due to the workforce issues. So there must still be a range of risk out there. And how do our front doors really make that assessment very quickly to ensure that we are getting this bit right?
If I can chip in first, and then maybe others can follow within that. I think it's trying to ensure that one single door can lead on to different avenues within that. So, and what we found on the challenge event, one of the strengths that we have in Kirklees across the partnership is people know individuals across the different services. So we talk a lot about the boundaries between services, health, adult social care, the police, others, voluntary sector. And those boundaries are lessened to a great deal when actually people know individuals across the boundaries, and they're able to lift the phone and talk about cases. And that happens now, and it's something we want to encourage. As staff teams change, you need to start it again. So we have to ensure that this is ongoing work, that people tend to know each other's services really well. So whichever front door you're talking about can actually open onto another one behind it, and that has to. talking about being proactive, if I give you one very quick example, that we have a story which is presented at the beginning of every Safeguarding Adults board, and the police presented one there. One of the areas of abuse which is on the increase, unfortunately, at the moment, is around fraud and people actually tricking people into giving over them their money and their life savings within that. Well, the police in Kirklees have been very proactive around this, and they've created, I can't remember the term of it now, but there's a project that they have in place now and has been in place about 1.5 years, maybe 2 years, across all of the banks. And they're linked to a number within the police that if they're suspicious around a transaction, if someone comes in with someone who's supposedly supporting someone removing some money from their account or whatever, they will keep them within the bank until a police officer arrives. And that's been going very successfully. And during the challenge event recently, the police were saying they're getting at least one call a week where those incidents are happening. So that's them being proactive around an increase in crime and abuse, which is taking place, not just with the elderly residents, but also with people with learning disabilities and other issues within that, who are being coerced into giving over their savings. So that's an example of how those have been proactive. The front door element, I think, is always prevalent, and the good practice is that we can transfer and share cases across those boundaries between the different agencies. But as I say, a lot of that is personal, which is good, that people can actually pick up the phone and talk to individuals in different services. So, and I do say that is a strength in Kirklees.
Okay, thank you very much. Thank you, all of you. Thank you, Rob, Richard and Jackie, very much for your time. I also had the opportunity to attend the Health and Wellbeing Board where you presented, and it was quite evident there that you've got really good relationships as a partnership. There were more partners there, obviously, at that stage. So we really appreciate you bringing this report to the panel, and thank you for your time today. Okay.
Thank you very much.
Thank you.
Right, we'll carry on if that's all right. We'll move forward to the work programme. Do people need a break? No? Are we all right to move on? So thank you, Richard. I think you sent us a flow chart to assist us around what we're doing with this work programme. So we've obviously got our little flow chart in the papers, reviewing what we've done this year and perhaps teeing next year up so that we can hit the year reasonably running. So, and I don't know, hopefully you've all got a report that I did about where we're up to, or at least my perceptions. So of what we've done this year and what we've noted. So, right, Richard, you've more experience on doing these than me. Do we just go through the work programme? Are we happy to do that? Yeah. So we can do the work programme, cross-check it against the end of programme review. Richard is staying as an officer to help us with this part. So that's fine. Yeah. So we'll I'll have to turn my flow chart out if I'm looking at the work programme at the same time. So if we hit it in the order that we actually have got it on the work programme, resources in Kirklees Health and Adult Social Care Scrutiny, I think we are looking at 2.14 on my place. And this is the discussion that we had actually about workforce and money, if you remember. And I think we learned that we are not only short of money, but actually our biggest risk across the board was basically workforce, which I think we've highlighted. So I don't know whether, I mean, clearly we had that discussion last year. I don't know whether there's anything that we want to pick out of that discussion or out of the paper that we will need to highlight for next year and how we move forward next year.
I'm just wondering if it's just an integral part of, for everybody that comes, that we ask the question. That, because I don't see that question, that going away anytime soon. So it's almost an integral part of, presumably, everybody who comes to speak to us or anything, any area that we look at, that is likely to be a major factor that people will cite, I assume. So as an issue itself, I don't know whether it's an issue itself or just something that is inherent within all of the other areas.
I mean, we did have some golden threads, didn't we? And we need to go back and think whether or not we did do those. One of the things that we did note, if you remember, was South West Yorkshire were actually underspending when everybody else was overspending it. And I can remember raising a concern about if we've got a lot of issues around mental health, how have we got an underspend in our mental health organisation? So perhaps that's something we could just recall for next year when we're meeting with South West Yorkshire and just see. And I think it was mainly around vacancies, wasn't it, that their response was. And their inability to get agency. But
and I guess I'm assuming those two things are together, that there's a lack of funding and difficulty in recruitment, but actually they could be separate, as you've just described, that there is funding there, but there isn't anybody to fill the job. So it is two separate things, funding and recruitment.
Yeah, it was just in relation to the overall theme around resources. It has traditionally been almost like a standing item that we've covered as part of the overall area that the panel focus on. Richard might want to comment on timings as to when we do that, but my view would be that it would be something probably that as a, for a panel to have an understanding of the overall position across the sector. I mean, as you know, obviously the challenges are still there. We know workforce is still a key challenge. And as Jackie has highlighted, there might be certain threads that you want to pull out from those discussions that we can focus on. But certainly in previous years, the panel have had found it very helpful to have that overall understanding. So my view would be that it probably would be useful to have it as another standing item for next year. Timing is always, we just obviously need to be clear about when is the best time to do that. I don't know, Richard, if you have any views or comments on that?
So probably logically one of the earlier meetings in the new municipal year, so that people will know broadly what the outturn was for the financial year we've just left, and will be able to describe resources for the financial year that we're in. Is perhaps worth Richard is just picking a conversation with finance leads and understanding when they'll have end-of-year accounts that are in a kind of public state, but probably a June, July kind of meeting.
I think we had it in October, which was the earliest we could schedule last year. So perhaps put down something similar, but make sure as well that we pick out of that the any areas that we've got to go.
Can I just come in on that one as well? Because obviously it's the same old. We all know that nationally social care has been put on the back burner till after the election. We know it was in the papers today, yet another cutback to some social care funding, and until we are going to pay a sensible wage. Now, whilst that is not in the remit of this board, certainly as public citizens, and certainly I will be one, and will able to lobby, I just think we all have a duty to just shout out from the rooftops that we can't keep trying to pay people, as I've said many times, more to walk a dog than look after old people, and it's only going to get worse. And people like Richard and all those of you here and in the council are going to continually be up against a brick wall. So, you know, we can't say that specifically in this, but I just think that those who can and free to lobby until it becomes the #1 priority that is dealt with an ageing workforce in this country. Not workforce. Well, it might be ageing workforce, but it's also an ageing population.
It might be something that we could ask specifically under here around how we are paying in comparison, certainly health, social care to health, social care to minimum wage, etc. It might be something that specifically we could look at, because there has been an expectation, hasn't there, that people will move from from social care into health potentially, or at least to have some parity around pay. So we could perhaps get those figures as part of that.
And my understanding is that it's Scrutiny's responsibility to highlight any risks to services and the public. And if resource in whatever form is an issue, then the panel has a responsibility to flag that and challenge it. Whilst it might be out of the hands of the officers at the time, it's still an issue, I think, that we have a responsibility to raise.
Well, I think we've got a vote for picking up the resources again next year, perhaps with a little bit more detail, but we can test that as we get into the new year. We, if you remember, said that we would look at impact of COVID throughout the year, and we didn't pick it up as an individual conversation. I don't know. We did have some discussion about excess deaths. Would you remember? I don't know whether it's a conversation we want to pick up again next year, or is it something can see you?
I was just wondering if, because there will be an inquiry nationally, as I understand it, at some point, it might be helpful to have some picture of ongoing issues related to COVID, in terms of, you know, we've talked about sort of even staffing levels and complexity of cases, as well as excess deaths. And if there are individual organisations who are doing their own review of their reaction during the pandemic, it might be helpful to have some of that information here that might help us going forward.
So is this one that we should, Richard?
So I wonder whether there's two separate issues. One is, as you say, will get picked up through the national inquiries, which is the response to the pandemic as a kind of national and local organisational level. The other is almost the COVID legacy, which is perhaps what people are now talking about, that sense of increased acuity, complexity, the impact of the period of lockdowns in terms of people's longer term functioning, perhaps a link through to kind of workforce impact. And it's probably worth thinking, I think, of them as two distinct areas. One potentially covered off through the national inquiry work, or the national inquiry work might get to a point where there's a logical question to say, well, that was the national picture, what was the Kirklees picture, an individual organisation picture? And it's probably worth doing all of those things together. And the other is, I think, getting underneath the COVID legacy plans to address that on longer term impact, because that, I suspect, ties into some of the other pressures we've talked about through the course of today, and will probably help the panel understand going forward the basis of a number of challenges in the system, or ways in which the system will need to work differently to respond to that legacy.
I was just going to say, because I understand that there's another booster jab coming as well for people with the immunosuppressant challenges, etc., and other health things. So it's not over, but it's just, I mean, even today we've talked about how COVID is still a factor for services. So I don't know how big that is or not, and I guess we can, if we think that's not relevant anymore, we can take it off the work plan. But it still feels like it's being cited when we talk to people, it's still being cited as a reason for there being challenges within services.
Okay, all right. Well, let's keep it there. It may well be one that we keep an eye on all year when we're talking about things like workforce, when we're talking about throughput and things like that. Because if you look at some of the stuff that we've had from the acute hospitals, for instance, they're still reporting on the number of COVID patients, and it's definitely having an impact there. So let's keep that one as well, or at least keep it as an overall. So our third one that we did was in October, and that was about capacity and demand. I'm just having a look. So clearly a lot of it was around managing the waiting lists down, if you remember, and how people were actually catching up. I know certainly when we were at the workshop on the 30th, it was very evident that CHFT are doing very well and Mid Yorkshire are struggling to do that catch up. I'm sure we'll have to do something around the waiting list next year just to see where we are. Is that kind of like a common?
I was just going to say, I think that's really relevant because obviously we've got some commitments from both trusts to remain on track to hit 52-week wait by March 25, and it will just, I think, be useful to revisit that and see what the situation is. Because all this is kind of anecdotal, but I think it'd be interesting to have the hard figures and see where they're actually up to and whether that trend is still the case.
I think we were told at this time that we got about 100 patients in beds for both acute organisations, hadn't we, that were delayed due to capacity out in social care. And I know with this year we've had a kind of like more focus on social care. I'm tempted to say separate next year again and do waiting lists as waiting lists and social care as social care. What do you think?
Yeah, I think that will be useful. I think we've got some added challenges, haven't we, as well, in terms of the strikes that have taken place and the doctors' strikes, particularly with health as well, that may have impact on the trajectories.
Well, we're doing very well at keeping everything on.
Not unusual.
So, right, we're talking about joined up care in Kirklees neighbourhoods now. I have a feeling that we're going to end up keeping some of this on because if you remember, we talked about the primary care networks and really basically capacity out in the communities. So come on then, people, your thoughts around this?
Oh, sorry about that. I do believe that we should actually keep it on. It is a relatively new thing there. Is some of the answers that we were given last time, I was sort of quite sceptical about all of these lovely community diagnostic centres, etc., where you kind of knew that the one in Huddersfield would be in the university health thing there, and looking again is sort of things like the one is why wasn't there anything in Dewsbury? Again, residents in Dewsbury would be going to Wakefield for the things there, and it would be good to have an update on how far they've progressed in the last year.
And following on from that, just to say, when we had a very briefing, Councillor Greaves last week, or was it the week before, it did feel that it was still at a very early stage. There's been such a delay in the reorganisation and how it's going to work, and wards following the PCN pattern. I think To use the word I've heard a lot this year, deep dive, it seems to me we could do to look at that in more detail. But I know we're just adding to what you're going to be doing.
And the community pharmacies as well. I mean, that... Apologies again. The government have only just, recently basically reformed or provided introduced a reform scheme for pharmacists. So I'd like to know how that's working as well, because to be honest, I think the lady said that we're going to lose more pharmacists, so I think that's a concern. So I think I definitely think we need to see how that's working.
There was a specific issue as well around a pilot that had taken place around, I can't remember the name of it, but where Huddersfield University had done an assessment of it and they were waiting for the result of that with the health support workers, not health support workers.
Paramedics?
No, it was with the, it was a pilot anyway, and it had finished and we were waiting for, I think that was going to be in May or June.
We'll have to check on that.
Yeah.
Thank you, Touche. The work that I'd noticed about Huddersfield University was just about paramedic training, but we'll check on that and make sure that we know what that is. Yeah. Okay. So more of a deep dive into PCNs. Richard, any comment? Anything?
Conversations have been in about making the distinction between services and health services in the community and community health services, and recognising they are two very different things. And I think that notion of health services in the community will be an interesting thing to revisit as the primary care networks get more and more things that they need to deliver. We think about the continuing role of community pharmacy, reflecting back, we talked earlier about the pandemic, actually they played a very big role in the vaccination programmes, and perhaps just revisiting where a number of those things are getting to. It's really about moving to a space, I think, where it's less who does something, but how does it all join up? And in a world of workforce, people are making the best use of the workforce that is available. So I think it would be helpful to revisit that. There's also a thing called the Fuller Stock Take that got published earlier this year. It talked about, in a sense, a new ambition for the primary care networks, and then becoming much more kind of embedded as part of a kind of community or neighbourhood kind of health team. So I think that will all be helpful work to revisit.
I agree, and I think because it was so new last year, and so there were lots of we hope to, we expect to, we would like to. I think it's then good to come back and review, okay, which part of that have we actually has been achieved and what's the impact on the community.
And it would be remiss of us not to have a look at people's satisfaction around accessing GP services, for instance, and things like that. So we'll put that on. Sorry about that.
Just duplicate this.
Just deep dives in all of them. Okay, so we did have a discussion back in July, mental health and well-being, which we've covered on here. Again, workforce, out of area beds. The whole point of the discussion that I was having in the informal was to try and pull people back into in area beds. So we are definitely going to have a discussion, aren't we, about mental health, if not just focused on inpatients, on access to mental health services.
Is that less of a deep dive and more of as a result of the meeting last week?
I think we'll have to wait and see what the discussion is around older people's mental health and what comes from the discussion that the commissioners are having at the moment around older people's mental health and acute adult, and then we can actually factor in something to discuss either that is specifically or something that's a bit broader around are we meeting. We understand from what we've already picked up just in this meeting in Safeguard, but it comes up every time, doesn't it, that actually there's a lot of unmet need around mental health services. And so we probably need to get into that a little bit deeper as well. And that was partly my point about we know that there's a need, but actually we haven't spent all the resource. So are we looking at things differently, or are we just doing what we traditionally have done in the past? Right, so we're on to unplanned care. I could be persuaded on this one. So this is about, we talked about how difficult it was for people to access services when there was a more acute need.
Sorry, I was going to say, could this link in with the stuff that we're saying about the integrated care and place-based services and community services that we just talked about? Could that be?
Certainly the GP access could, and I'm thinking maybe when we talk around resources and things we could put into there. Don't know. I mean, there's a very definite flow that we need to happen, isn't there? It's just about whether or not we feel unless we're concentrating on that flow, we'll actually pick it up across. Ideas?
There is a lot of overlap if it was worded in a certain way, because a lot of the unplanned care does relate to health and adult social care. Resources is an ongoing issue. It feels like every single thing we look at is first of all underpinned by resources, skills and expertise almost, and finances. I don't know.
Right, let's put a query against that one, as long as we can make sure that we pick up, because it would be, I think it'd be remiss of us not to note things like 12-hour trolley waits happening still, and that throughput. And I don't think we would pick all of that up under adult social care. We would just focus on that back door.
I agree. I think we might miss the gaps if we don't do it, because unplanned care really is plugging the gaps where services either haven't been able to meet that need or they're not in place yet, and then it results in unplanned care.
Okay, I agree.
So having sat through a number of the kind of annual reflections on work programme and future year's work programme, it strikes me that a number of the things that are on the work programme are long-term strategic multi-year pieces of work. They're not things that get started, implemented and all sorted out in a 6 or 9 month period. I suggest actually if they were things that were that simple to do, they're probably not things that should be a priority for the scrutiny panel to be considering. You're considering the wicked issues. And so actually the fact that things are on programmes for multiple years is probably an indication it's, to an extent, those are some of the right issues to be looking at. There's also then, I think, something about, there are some set piece things, so we had that today in terms of the safeguarding adults piece of work. There's the bit about the kind of almost an annual finance conversation. But then I wonder whether there are some things that might be picked up periodically, perhaps quarterly, which is not necessarily going into a huge amount of detail, but which is some of that kind of high-level performance of the system. And that might then allow you to say, broadly, we're we have an insight into what's happening in terms of people's experience and performance across the health and care system, and that might lead to a change in the work programme down the line if there's a set of things that appear to be going in the wrong direction over a number of months. And so there's perhaps a bit of, what are those things that are kind of in scope really for monitoring, or in sight for monitoring, and what are those things that are in scope for a deep dive, where some of that deep dive might at the start be understanding the issue, but comes back periodically because actually the panel's rightly concerned to understand what's happening in terms of progress and delivery against them.
Thank you, Richard, and that's really helpful because this year we did say that we would always try and triangulate with the data, and to be fair, we haven't actually had much performance data other than the sit reps that we're getting from the acute trust, so we perhaps need to look at how we get that tightened. Because the sit reps are very useful for us as well. So, for instance, we understand how many acute beds are open above their normal bed base, and at what bed occupancy we're at. But we haven't got that information across the board. So I think that would be really helpful for us to work on.
Did we get CQC data? I think were they due to come and they didn't come, or they were? I do have some memory of talking about them coming here.
Yeah, they didn't come to the meeting. They were supposed to come.
CQC has in the past been a standing item where we've invited them to come so they could actually present the state of care in Kirklees, so that the panel has an understanding generally across all of the various directorates. Because of the level of work we had on our programme this year, we weren't able to get them in to actually do that presentation. So I think they are on the work programme, so that's obviously, we will need to discuss the approach that we want to take in relation to our communication channel with CQC, whether we formally invite them to a meeting or whether we just utilise the data that they have to help inform the panel. And that goes back, I think, to what you're just saying there, Councillor Ramsey, about performance data, whether it feeds into that element to help sort of provide that overall profile of the state of care in Kirklees.
That was my thinking, that is a piece of data that could be helpful, even if we haven't got space to have that conversation with them about if they were willing to provide us with that information. It's at least one piece of data.
So maternity, I think we're all well briefed on our maternity issues. I don't know. We did say that we would invite the maternity services to come back to us to talk to us about the birthing units once they're in a state to do so. Obviously, we've got the second letter out now to chief execs. I'm hoping that during the kind of like election period, or whatever you want to call it, the kind of like recess, we'll get some response for that, and we should schedule that, even if it's for a short part of the meeting. We should schedule it. We can't, and we must make a decision on whether or not we're going to do something more public about this. So that's staying. Let's have a look. Where are we up to? We haven't chosen anything to go yet, but thank you very much, Richard, for your reassurance around the fact that dentistry can't go anywhere either, can it? Obviously, we've just so we'll have to schedule that as well. Bill concerns, obviously you've seen the letters that have gone with regards to particularly that general anaesthetic access for children. So we've just talked about CQC. We've just had the safeguarding report. do we think? So we've said CQC possibly just receive it as information and just have it there as a background for data. What do we think about the safeguarding report? Do you think that would be acceptable to have that as background data, or have you enjoyed? Yeah.
Personally, I think it's important to hear the information from Safeguarding Board. I always welcome more data and information and specifics of what's happened as a result of action, because it was high level, and I understand why it would be high level. But I find it more helpful if we've got specifics of what's changed and what's different and what different action's been taken. That's just a...
So if we receive this report without the kind of presentation and then had, I wonder if next year we could have some kind of method of having a discussion amongst ourselves around what are the key issues that we'd like to ask the issues, and then get people to come and talk to those rather than the basic. What do you think?
For me, I think that would work quite well.
I wonder whether there's something about combining the safeguarding report conversation, the conversation with CQC, because feels like there's quite a lot of overlap in those, and that will give you, the panel, a sense of quality and safety of certainly social care provision. And CQC equally, I think when they've come in the past, have offered an observation about all the regulated services across Kirklees. And there's always a balance between holding meetings in public and having a more of an informal workshop, and I think sometimes that CQC conversation has worked well when it's happened as more of a workshop in terms of kind of being able to get into some of the kind of conversation. But I suggest perhaps, you know, having those two in the same conversation might give one a more rounded kind of picture.
I think because we haven't seen a CQC report, we don't yet know what we'd want to sort of ask questions about. So that's, I agree with Richard that that's, you know, it seems to be the most sensible approach.
So do you think we could have circulated the latest CQC report, and then when we actually do come to agree in because obviously we'll draft something up to be agreed at the first meeting next year, hopefully, we're at least able to have a conversation about the kind of things and whether it is a workshop discussion or it is a more formal meeting discussion.
I think we need to be clear about what you mean by CQC report.
Well, is there an overall CQC,
well,
or do we just ask them?
We've usually asked them to attend to provide an overview in relation to the various directorates that they that they monitor. So that could include dentistry, that could include primary care services, it could include acute hospital trusts. Well, in fact, all the major sectors across the health and adult social care sector. So it's whether you want to have a broad overview across all of those sectors, which is fine, or whether there is a particular area that you feel that you would want them to focus on. So we would have to give them some indication in terms of where we would want to focus.
Because we don't know what they produce, would it be better to have at least have an overview one? If that's something that they already have.
They're not producing anything particular. This will be them putting together a data pack that would reflect areas that maybe that we have suggested we would like to look at. I mean, obviously their website, we can access any reports that have been done, but it's quite difficult really to sort of pull that all together. So what I can do, if it's helpful, is I can circulate some of the presentations they've done previously, so you've got an idea in terms of some of the data that they have presented to the previous panels, and that might help members in terms of maybe just focusing on whether they find that useful or whether there are other areas that maybe they'd like to have more information on.
Yeah, I think that'd be helpful, wouldn't it? Richard, were you going to say something?
Yes, in the past they've often bought 80% of care homes in Kirklees are registered good, and this is the distribution for primary care, the inspection for dentistry, and so off the back of it, one's had a sense of the state of quality for different sorts of care in Kirklees, and they've been able to do a bit of have a bit of a conversation around some of the themes that they're seeing in Kirklees versus the the broader footprint that they operate over across the region. And again, whether there are some consistent themes that might be emerging. So some of that, depending on sequencing, there's a bit about the resources available in the system, there's a bit about the quality, might almost set up context for the deep dives further on. So if, they were flagging there's a particular issue around primary, the most recent set of primary care inspections, for instance, that might be something you would then want to pick up later on in the year, and if you're doing a more focused conversation about healthcare services in the community. And it's all likewise, if you alluded earlier, there are differences in the underspend and overspend position of organisations at the moment that was going to inform a later conversation. So that might be, almost as a session of background conversations that establish a baseline for the panel and then inform those later conversations later in the year where you might come back and revisit some of the themes that emerged.
Yeah, I was thinking pretty much along the lines of, I wonder if we task organisations to actually report on their CQC, when they're coming to feed. So, because we're saying that we've actually got a little gap here around data, I'm just wondering how we could perhaps do that. We'll have a chat, Richard, but yeah, let's provide the overall and then we've got that. Our next one was inequalities of access to healthcare services. I'm afraid I don't think we've completely bottomed this one either. Well, we can perhaps schedule that a little bit earlier if we feel that we want to go back on that. The whole point about this is so that we end up not repeating what we've already done, that we take where we're up to. So we'll perhaps have a little look through this and see what our questions can be for next year around inequalities. But yeah. Oh, new PAM for adult social care reform. Okay, well, we are definitely going to have something around adult social care, aren't we? Richard, do you want to highlight perhaps what we need to cover? Because we've talked this year, haven't we, around the need to kind of like transform services as we move forward. So perhaps we could do some guidance about when we think we'll be ready to talk about what kind of decisions might be made around assistive technology, workforce, etc., moving forward, because then at least we can schedule it around when might be a good time.
So I think we'd originally anticipated bringing a conversation about social care reform, which has obviously been postponed to October 2025. And just because we were talking earlier about deprivation of liberties, and I said they're being replaced by liberty protection safeguards, I just had a little message pop up to say that liberty protection safeguards have been postponed to at least 2025. I thought I'd just raise that because we were talking about that a moment ago. I wonder whether there's we're obviously stepping into a space now where CQC will inspect councils in the same way that Ofsted inspects councils, and therefore whether that should be an area of particular focus for this panel to understand more about the assurance regime, the preparations that this council is undertaking, and the emerging, there's not yet complete clarity about how it will work from earlier this month, but how, what appears to be emerging in terms of the approach to pilot sites and then the next cohort of councils that will be inspected, so that if we get the phone call to say that there's going to be a CQC inspection in the same way that children's get the phone call about an Ofsted inspection, the panel will understand what the council will be going through, and perhaps think through that might help shape some of the questions this panel might want to be asking in terms of accountability for performance and quality in social care.
I certainly think that's a good part of it. I think what would be helpful as well is just to make sure that we understand how workforce issues, etc., next year are being addressed, because we know about the growing demand, the acuity, etc. We'll have to revisit that as well. Okay. That brings us to palliative and end-of-life care, and to be fair, I think we were quite assured with that, weren't we? Yeah? So that can come off, Richard.
Can I just add one thing there, though, which I mentioned at the time, was the plea I had from some of the staff there, which is not the brief of this group, but to be aware that it's a topic that needs much more discussion and education and in schools, and getting away of the fear of death and palliative care and all the rest of it. And in an ideal world, even making a visit, because they are just inspirational people, and I think they need to have, people who've had experience will clap from the heavens of them, and, clearly the conversations in the middle of the night where they were saying, we just need to do so much more in education, which is not this brief, but it would be good to think there was some way of bringing it in somewhere. Although more and more of our schools are becoming academies, it might not happen, but anyway.
Okay, well, we can just talk to Children's Scrutiny, can't we, and say that we'd particularly thought that the end-of-life and palliative care was good, and that they'd made the plea around a broader education around dying well, basically, which I know that was discussed at Health and Wellbeing Board as well, so that's good news. So, is there anything else that we want to pick up? That's the question. Have we had discussions this year that we've said we must focus on that next year? Can't recall any.
No, I think everything that we've captured is in the work programme and in the end of year report. And just in terms of next steps, just to confirm, the idea will be that we'll use this discussion now to start shaping the work programme for 23-24, and then the intention will be to share that with colleagues within the council, adult social care, public health, etc., but also partners across wider health for their comment, and to also ask whether they feel there are any areas that they believe we should be focusing on. And then hopefully we'll take that all into a workshop, probably early in the new municipal year, where informally we can then have a detailed discussion with partners and colleagues from the council invited, to hopefully then finalise and just make sure we've got a programme that everyone is comfortable with, is robust, and we're clear about some of the timescales. So this is kind of like the first step, if that makes sense, in sort of just obviously refining that programme.
Can I just raise something? I'm not sure. We fleetingly mentioned it last week at the workshop meeting about virtual wards. I mean, I would like to understand how they work and what impact they're having on healthcare generally. It's something I've never previously come across. I just don't know what the rest of the panel feel about that, and how can we be assured that particular patient is getting the right care in those virtual wards? I don't know. Come under basic.
I think probably we could fit it in under the unplanned care discussion where we're talking about the whole flow, because it's around admission avoidance and enabling earlier discharge, isn't it? So it should be part of that suite, I think. But we can make a note that as yet we haven't had the level of detail, if you like, around the virtual ward, and I think that's been noted before as well, hasn't it? So yeah. Okay, shall I draw that to a close? So your homework for the recess is to look at the golden threads and to make sure the golden threads are still valid, and to think about what data we really need to have on a regular basis so that we are doing what we said we would do, which is triangulate some of the stuff that people tell us. All right, so thank you very much. All right, and thank you. Leslie, a particular thank you to you for being a panel member this year, and we will be very sad to lose you. Okay.
And I'm really sad to be going. It's a shame you can't be on it just as a sort of, community member person who doesn't know a lot but likes asking questions. Yeah, but I don't have your expertise. I'm just a sort of,
I'm going to close the meeting.
Good luck.
All right. Thank you very much. Thanks, Tom.